All right, now you guys know why I always hound you to exercise, right? Raise your hand if I've told you to exercise and wouldn't let you leave. Thank you. Okay, good. Jan's applauding too. Okay, so now we're going to talk about the surgical treatment of Parkinson's disease, and that is deep brain stimulation. In the latter half of my presentation, I'm going to bring up Dr. Paul Wagaspak, who is, of course, a neurosurgeon at Neuromedical Center who has been doing DBS with me all along. He was actually involved in the very first DBS case ever done in the state of Louisiana when he was a neurosurgery fellow in New Orleans. So he's been around it a lot, and he's been a great partner to work with, as some of you already know. So today we're going to learn about which patients are candidates for DBS. We're going to learn how exactly it helps people. We're going to learn how it's done, and we're going to learn, of course, about the risks and the benefits. I can't talk about DBS, without giving a little bit of understanding about what the terms I'm going to use mean. So, of course, we covered all this in detail last year. We're not going to have a kind of a basic Parkinson's lecture every year, but the basic motor symptoms of Parkinson's disease are tremor, which most people know about, the stiffness and the slowness, known as bradykinesia and rigidity. We've got to have fancy terms for everything, right? And then postural instability, and there's a neat little acronym to help us remember these, TRAP. I should point out postural instability in true Parkinson's disease does usually come a little bit later. So the primary motor manifestations early on are the tremor, rigidity, and bradykinesia. So tremor, stiffness, slowness. Well, when you first develop Parkinson's, the medicines can really control you very well for a number of years. And there's various ways to accomplish that with different medications. But as time goes on, after you've had Parkinson's a number of years, you can start to develop what's called motor complications. And there's two kinds of motor complications. There's fluctuations and there's dyskinesias. And I'm going to explain what those are. Motor fluctuations refers to the fact that, let's say, most people, eventually have to take levodopa, some form of levodopa, for their Parkinson's disease, so Sinemet or Stalevo or generic levodopa. And at first you can take it 2 or 3 times a day and it works fine. You don't really notice that the medicine wears off or anything, but after a number of years, the medicine doesn't last until the next dose and you feel it start to wear off. That is, the tremor, the stiffness, the slowness seems to come back before you take your next dose. And so then you might go from 3 times a day to 4 times a day to 5 times a day, or even more than that sometimes. And so we call that wearing off. So we call off as when the medicine's not working and you have the motor symptoms. We call that the off state. And when the medicines are working and you're feeling pretty good about the motor symptoms, we call that the on state. So as time goes on, you have more of this wearing off phenomenon. You have to take the medications more frequently, very, very much more complicated as time goes on. And then even later on, people can have other kinds of complications called sudden offs, where instead of the medicine kind of wearing off slowly, it might suddenly wear off within a few seconds, and that can be a big problem, obviously. And then it's also true that as time goes on, that the medicine, you expect it to wear off at a certain time, but sometimes it comes unexpectedly, so we call that an unexpected off. And the longer you have Parkinson's, the higher the chances are that these complications can occur. So we call all of these collectively motor fluctuations. And then there's dyskinesias. These are the involuntary movements that you might see Michael J. Fox do in an interview. Just looks very fidgety, can't stop moving. And there's a spectrum, that they can be very subtle, very mild, not bothersome, or they can be very severe, bothersome, even painful, and debilitating. So we call these Dyskinesias. They typically occur when the medication levels are kind of a little bit too high, but they can also occur as the medicine is sort of kicking in or as it's wearing off. So there's different kinds of dyskinesias you can have, but they can be hard to control. So not everybody gets these, but by the way, not everybody gets dyskinesias. It happens more in younger people with Parkinson's, but most people do get the wearing off if they have Parkinson's long enough. And so what we want to do with the medicines, of course, is to minimize the amount of time that you're in the off state, minimize the amount of time that you have dyskinesias, and therefore that means that you'll have more on time, so more good time, where your motor symptoms are very well controlled. So now that brings us to DBS. So what does DBS do exactly? Well, it helps us reduce these complications, reduce the wear and off time, and reduce the dyskinesias. It's a surgically implanted device that goes into a deep part of the brain that's involved in the motor control circuits that are involved in Parkinson's disease. And I'll explain how it might work a little bit. It's a wire that we implant in the brain, and it's hooked up under the skin to a wire that goes behind the ear to a pacemaker-like device in the chest wall. In fact, the same company that makes the pacemakers, Medtronic, makes the pulse generator in the DBS system, and they call it the Activa system. So it's for people who, again, have true Parkinson's disease. They were doing well for a while, but then they start to have so much of these complications that it's hard to control them and regulate them with just manipulation of the medicine and the medication times. So in that individual, they're a good candidate for deep brain stimulation. And so there's specific parts of the brain that we put this wire in. And this DBS system is approved for other diseases too. So people who have a disease called essential tremor, which is actually more common than Parkinson's disease, we put it in the thalamus, or the VIM part of the brain. For Parkinson's disease, you can put it in one of two different places. The globus pallidus, which we call GPI, and the subthalamic nucleus, which we call STN. Here, we pretty much always put it in the STN, but these two are roughly equivalent. Some places do both, some do one or the other, but they're roughly equivalent. I think more people are doing STN nationwide and worldwide. But what we think it does, we're not exactly sure the mechanism of action, but what we think it's doing is by delivering a low voltage, high frequency stimulation to this very specific part of the brain, we think that it's overriding the abnormal firing in the brain that's driving these motor symptoms. So the brain likes to fire in an oscillatory manner in these parts of the brain, and so we think that we're overriding that somehow, but that's not known for sure. I mentioned it's approved for essential tremor as well as Parkinson's disease. And HDE means these two indications, dystonia and OCD, have a special kind of approval from the FDA for deep brain stimulation called a humanitarian device exemption, which really means these are so rare, these conditions are so rare, it's hard for companies to do the same rigorous level of studies that you can do in these diseases, so they give them a special exemption. It's not nearly as commonly used for those conditions as it is for essential tremor and Parkinson's. So how widespread is this technology? It's been used since 1997 or longer all around the world, really. We have over 80,000 people with DBS all around the world. We've put in over 100 here in Baton Rouge. I've programmed, probably a couple of hundred other people who've had it done elsewhere, and I just do the programming plus what Dr. Kader's done. So there's really a lot of people walking around, even the Baton Rouge area, with this technology. A lot of them in this room, who are doing rather well. We have over 2,000 articles on this technology, doing research showing how it's helping people. This is just sort of a diagram that shows kind of how the wire goes in these deep parts of the brain. This is a picture of the pulse generator that goes in the chest wall. We think that in the future we're going to have new indications for this, so probably DBS will be used for other things in the future, like maybe control of seizures or obesity or depression or other things that we're still looking at. So we may find different parts of the brain to use that are better. So they're constantly looking at all this. The technology is improving and evolving, and there's already been a couple of generations of this that have come out. Here are the dates. So 1997 for essential tremor, so it's nothing new, 16 years, and then was in trials well before that. Parkinson's approval since 2002, although it was used prior to that, even without technical FDA approval. And as I said, there's some other new indications lately. The current generation of technology in the Activa system, here's the 3 type of batteries that we can implant. We primarily do these 2 here. These 2 are non-rechargeable batteries. And single cell means somebody that just has one side of the brain stimulator. They can have this one. If you have both sides of the brain done, then you're going to need a dual channel device where both sides can plug in the same pulse generator. Or some people have 2 different single cells, one on each side. They do make a rechargeable battery, but you have to wear like a shoulder harness and you have to recharge it every couple weeks, and it's kind of cumbersome. These batteries really last 5 years, sometimes even longer, and it's really pretty easy to change out the battery. So we tend to use these just because it's less of a hassle. Here's the picture of the end of the wire that's in the brain has 4 contacts. And so you can see the 4 contacts here. 1, 2, 3, 4. There's 2 different kind of wires we could put in. They're exactly the same except for the spacing is different. This one has a little bit bigger spacing. This one has a little bit smaller spacing. And so this goes through the target part of the brain that I was talking about. And I have some pictures showing that a little better. But we can stimulate 1 or more of these contacts in a lot of different ways. I can stimulate just one, or I can do this one and this one, or I can do this one, this one, this one, and any combination is possible really. So it allows us to take the shape of the exact area of the brain that we're stimulating. I can manipulate the size and shape of that area to tailor exactly what you need for your brain. Everybody's brain is a little bit different. The size of their STN is a little different. It's shaped a little different. We're in different angles through it. So this allows me a lot of leeway in manipulating the field to tailor it to your exact needs and to avoid side effects. This is a picture of, we do a detailed brain MRI prior to surgery. So we plan exactly the trajectory that we're going to go into the brain to minimize the risk of complications. And you can kind of see that trajectory here. We go right into that part of the brain, which is where the STN is. And this is some different angles, how we get there. And we do all this planning the night before the surgery. And Paul's going to talk a little bit more about that. This is a good picture of where the leads actually are in the brain. So this is an MRI of the brain. This is a MRI of the brain done, or a CAT scan of the brain done, kind of looking at the brain. If you could think about the head being cut this way and looking from the front, you would see, this is called a coronal section, and you can see this person has bilateral stimulators, and those are the 4 contacts at the bottom. Now, it's not really that big, okay, but the metal at the bottom of the wire gives an artifact or a false signal that makes it look bigger, okay, so it's not really that big, but it does allow you to see exactly where we are in the brain. That's why it's called deep brain stimulation. It really is pretty deep in the brain. And these motor control pathways in the brain are all up in here. So this STN sends projections to all other parts of the brain down there, And so it indirectly affects a lot of other parts of the brain by directly affecting that part of the brain. This is a picture of what someone may look like in surgery. We use frameless technology here, so there's two ways to do it. You can put a big metal frame, you know, bolted to the skull, and it makes it it keeps the head still, so we can, you know, put it precisely in. But we use a different technology here. It's a little bit more comfortable for people. They don't have to have the metal frame on their head. Instead of that, we put these little screws in the scalp under anesthesia, and we use that for our localization and reference points in planning. And so this is what somebody looks like in surgery. And after Dr. Wagaspak makes the incision, under anesthesia, of course, and reflects the scalp back, drills a hole, and then we mount this on top of the hole. It looks like a kind of an oil derrick, a little bitty oil derrick, and this is what drives the wire into the brain under precise guidance. And patients are awake for this procedure, so that makes it kind of interesting. There's a lot going on in the room while this is being done, so there's a lot of equipment that has to be set up. There's a lot of monitoring equipment. We bring in an electrophysiologist who's been on, you know, thousands of cases. The Medtronic reps have been on thousands of cases, so there's a lot of experience in the room to handle all the equipment, to, you know, troubleshoot, to make sure we're in the right place and not in the wrong place. This is another kind of a color picture that shows this is the STN, so that's where we're going, and here's kind of a schematic of where the wire might go through it. And what we're looking at is while the wire is being advanced into the brain, we are listening to the brain waves because patients awake. That's why you have to be awake, so we can hear the brain waves firing, and we can tell by the firing pattern exactly which part of the brain that we're in. And there's a video that's going to show that in a second. But as we go in, we hear different firing patterns for these different parts of the brain. And when we hit the STN, it makes a distinctive sound, and we know we're there. So we want to make sure that we get a trajectory where we get a big fat piece of the STN in our trajectory. So in other words, if we were to come in an angle here and just hear that distinctive sound for just a small size, then we know that we're not quite in the right place, and we might move it back to get a better trajectory right through the middle of that structure where we want to be. Here's another cartoon that just shows this structure. Here's the STN here. So this brain's kind of been cut away at the top, but the deep parts of the brain are still exposed. And here's the GPI here, the other place we can put it, but this is where we put it, the STN and the substantia nigra that Dr. Camella showed in her slides is right here under it. Here's another picture of that, a little bit more blown up. Here's the kind of a little animation that shows us where the wire goes in the brain. Let's see if this works. Ooh, not working. Yes, it is. Okay. So it's peeling away layers of the brain until we get to this STN and we can see it. Okay. So the other parts of the brain are being peeled away, and now it's just showing us all these deep parts of the brain together. And we're going to introduce the wire. So here's the first wire that we put in the brain with the little oil derrick, and it's advancing it slowly. You hear the sound? So we're in the thalamus now. And so we hear a little bit of thalamic firing. Sound's not very loud. Okay, now it's quiet again. So we're getting near where we're outside of this region. It's quiet. We're about to hit the STN. Should make a noise. Okay, we're hearing it. It's not very loud. I apologize for that. But it sounds like a lot of static, basically. It just sounds like static. And so then we're hearing the static. There we go. All through this structure. And then when we get through it, past it, now we're in the nigra, and it makes a different sound. So now we know that in this case, in this theoretical case, we had a great path through the structure that we want to be in, and that's exactly what we want. So then we'll take the recording electrode out, and then we would put in the wire that's going to stay there with the 4 contacts on the end. And you'll see that come in the picture. So now we're advancing in this exact same track that we know is the right path. Go into the subthalamic nucleus, and we want to put it so that, 1 or 2 or 3 of these contacts at the end of that wire are going right through the middle of that structure. And that's what we see. And the red shows that, this person is being stimulated. We're doing a test stimulation in the operating room to make sure that the person's motor symptoms, the stiffness, the slowness, the tremor, are lessened when we turn it on, and they're off their medicine since midnight the night before. And we also want to make sure that when we turn it on, that we're not stimulating one of those other nearby parts of the brain, because if it does stimulate the other nearby parts of the brain, then we get side effects that we don't want, such as tingling that doesn't go away, or motor contractions, or slurred speech, or double vision, or any of those sorts of things. Usually not anything painful, but things that we don't want you to walk around with all the time, obviously. So this is just a slide that shows this other part of the brain that we can use, the GPI, and we can stimulate, like I said, 1 or more of these contacts in that structure. So the people that I'm seeing for Parkinson's, I can tell when people sort of need it, but people that are seeing other doctors, I have no control over that. So we like to try to spread the word to make sure that people know and doctors know when is the right time to see a movement disorder specialist, to maybe see about getting deep brain stimulation. And then the other problem is some people who really want it, they're not candidates for one reason or the other. And I'll talk about some of the things that will make you a candidate, some of the things that won't make you a candidate. So we know there's over 1 million people with Parkinson's in the United States. We talked about how the medicine helps people for several years, but then they start getting the complications. And those are the people that we want to select. So this is a slide that shows, kind of the fluctuations that people have. These are people who start to have the wearing off and the dyskinesias. So this person here, let's take the yellow line. This is somebody, the blue line, somebody who does not have DBS, and they take their medicine here. It hasn't kicked in yet, so they're in this off state, and the medicine it goes up and crosses this threshold where they start to have more control of their symptoms. They're doing well here, but then we overshoot the mark with the medicines, and the high level causes dyskinesias. And then the medicine's cleared out of our system by the liver, and then this pattern repeats itself, X number of times a day. Some people up to 12 times a day have to do this, and this is a 2-hour cycle for some people, but for most people it's every 3, 4, 5 hours that they're having to deal with this after they've had Parkinson's for a number of years. And then you take somebody with DBS, and so how does it change them? Well, it smooths out the curve a little bit. They still have fluctuations. This is not a cure, but it treats the symptoms, and they have, so as you can see, they have less time in the off state, less time with dyskinesias, and maybe dyskinesias aren't as severe as they were before here, okay? And the off states are not as deep as they were before. So it smooths them out, and they have better control. Again, still have fluctuations, but better control. They looked at studies, evaluating how much of the off time is decreased. Well, as much as 5 hours a day. So 5 hours a day is a lot. If you're awake 14, 16 hours a day, 18 hours a day, 5 extra hours of good time is, of course, really good. We looked at how is this effect sustained? So the disease still progresses even though you have this technology and this treatment. This line here, the first line, shows we have 60, 70% something improvement in our motor scores in 1 year after DBS. And if you look at 3 years and 5 years for these symptoms, the effect is pretty sustained, although it does go down a little bit because there is progression of disease. We can turn the stimulation level up a little bit over time, but there is a finite level where you can't turn it up anymore, because then it starts to stimulate the other nearby structures, and at a certain point there's just no way around that. So it continues to help you, but the disease can sort of outpace the technology. The advantages of DBS over just the medicines are several. We talked about 5 hours more good time. The stimulation is constant, unlike the medicine, which is fluctuating, so it's more predictable. You don't have to worry about GI absorption, because it's just direct stimulation to the brain. Instead of the pulsatile delivery, it's continuous delivery. That's what we like in our treatment regimens at all times. Before you get the surgery, I like to do a test called the on-off test, where somebody comes in the clinic off of their medicines since midnight the night before, and I do this UPDRS, which is the official Parkinson's rating scale. It kind of puts a number to how severe the motor symptoms are. The patients take their medicine in the clinic, we wait for the medicines to kick in, and I do some of the test over again. And we like to see a 30, if not 50% improvement in the motor scores. That establishes that A, you are a responder to the medicine, which is necessary, because if you're not a responder to the medicine, then you will not be a responder to deep brain stimulation. So if the Parkinson's medicines don't work for you, then DBS won't work for you either. So who are the people who are not good candidates for DBS? Well, as I just mentioned, you have to be a responder to the Parkinson's medicine, or this won't help you. So people who don't respond to the medicine, they've got up to an adequate dose and it doesn't help them, then DBS is probably not going to help them either, unfortunately. Special exception, there are some people who can't take enough medicine to help them, and in those special cases we may still be able to do DBS, but we have less certainty that it will help them, and they have to accept that risk. People that fall a lot even when the medications are working. So when you're in the on state, medications are working, and you're still having a lot of falls, you may not be a good candidate for DBS, because the DBS won't help your balance per se. So if you're having a lot of falls, that really impacts your quality of life to such a degree that helping the motor symptoms may not improve your quality of life at all. If you have significant depression or anxiety, may not be a candidate. And we screen for that with detailed neuropsychological testing, and we have 3 neuropsychologists at the Neuromedical Center who do this for us and help us with this. Of course, if you have other medical problems that preclude you from getting a surgery, severe heart disease or lung disease, etc., then you may not be a candidate. If you have a bleeding disorder, you may not be a candidate. So there's some rare things there that can preclude people. Not on here really is if somebody's real elderly, say in mid to upper 70s, especially in the 80s, the brain starts to shrink as we get older, and that causes increased risk of bleeding in the surgery. So we be really careful about that too. Some controversial issues are, at what age do we stop doing this for the reason I just mentioned? We test people to make sure they don't have memory loss. If somebody has dementia, that's a contraindication. But what if they're not quite demented, but almost there? So where's the cutoff of where you let somebody get DBS and where you don't let somebody get it? How much depression or anxiety do you tolerate? Because sometimes DBS can exacerbate those conditions. And then there's the people, like I said, who maybe can't take the medicine, so how do you know if they respond to it? And then the balance issues I talked about too. The main risks during surgery, bleeding. During surgery, the main risks are bleeding in the brain and seizure. That's rare. It's less than 10%. But in some of those, in a lot of those people that are included in that 10%, the bleeding is very mild and really may not even cause a big problem. But of course, it can be big and cause a stroke or even death theoretically. After surgery, the risks are that the pulse generator can get infected. The lead can get infected. It can move over a little bit, and But these things can be treated with antibiotics. In rare cases, we have to take out the battery, let the infection heal, and then sometimes we can put it back in later. The lead can break or move in the brain. That's pretty rare, but I have had one patient that happened. If we're not in the right part of the brain, or if we didn't put it in the right kind of patient, it may not work. That's always a risk. And then if I turn it up too high or stimulate the wrong place, that can lead to side effects, but that's reversible. And this slide talks more about these reversible side effects that you can get from stimulating maybe in not quite the right place, or stimulating too much. And these are things that can happen, but of course, patients have a controller. They can actually turn it off anytime they want. If they feel it's doing anything bad, they can just turn it off and see if it goes away. So that's nice. Here's the programmer that I have in the clinic that I hold it up right up over the battery, and I can program it right through the skin with this on-screen little computer here. I just touch the screen and change the settings. It transmits the signal through the skin into the battery, and I have 100,000 different combinations or more of different settings I can use to tailor it to exactly your needs. This is a video that shows a lady who has had DBS. First, we're going to see how she does. First, we're going to see how she does. She is not on her medicine, and she has not had DBS surgery yet. So Parkinson's frequently affects one side more than the other. And this is after her DBS. So you can see it really quiets down the tremor pretty well. Okay? It's not always that dramatic, but in that case it is. So now I'd like to bring up Dr. Wagaspak, who is going to talk a little bit more about the surgical aspects.
Thank you, Dr. Kader, in advance for yielding some time. Dr. Calegan talked about a lot of the patient selection issues, and truthfully, that's probably the most important aspect of it. I'm fortunate to have 2, now 3 fellowship-trained neurologists, and the patient selection issue, mostly on their behalf, is the most important issue. But in general, there are a few cases that someone really shouldn't have surgery from a surgeon's point of view. The main thing is dementia or other cognitive issues. The meat of the operation, you have to be awake and you have to participate. There are some centers, I guess you could do it just by imaging, but to get the best clinical results, it's nice to have the patient interactive in the operating room so we can see what kind of effect and what kind of side effects we're going to be able to have. We're also very fortunate that at our center, the neurologists themselves are in the operating room with us, interacting with the patient, the very one who's going to be programming you in clinic. So it's really important, and it's not just about being demented or not. You have to be able to participate, and you have to be able to handle all the rigmarole of going through the operating room and all that kind of stuff. We consequently try and minimize the time that you're awake because that tends to be a limiting factor. And currently, we usually get started at around 7, and usually by 10 o'clock or even earlier sometimes we're done with needing you to be awake. So we need you to be able to be awake and participating and interactive. Bleeding disorders, if people obviously are on medications, most of the time can be stopped temporarily. Anytime we do surgery, there's a risk of bleeding, and if you have a bleeding disorder, and if you bleed in the brain, it can be absolutely devastating. Some medical conditions that can predispose you to bleeding or other things. Not very common that we run across something that just cannot be dealt with. And then some structural abnormality in the brain. A lot of times, we don't necessarily know, but we get a preoperative MRI for planning, but it also tells us if there's a tumor or a vascular malformation or something like that that's in the way. We've had 2 patients that have had some slight brain abnormalities that we've been able to work around and come in through a different angle, and they've been able to get stimulation okay. Where do you point? There we go. Most of the preoperative work is done by the neurologist. Some patients come to me because they heard about DBS, and we'll talk about it, obviously, but then before they're a candidate, I make sure they see one of our movement guys to make sure that they're the right person and the right setting of their disease. MRI is about the main thing that I need to get going before surgery. There have been a case or two where someone can't get an MRI because they have a pacemaker. We can do it with a CAT scan. We prefer an MRI because it gives us a lot more information, but it can be done with a CAT scan. The MRI has to be done with a certain protocol because we put it on the computer and reconstruct the images so we can plan our targeting. And then scheduling. It takes some time. My schedule, his schedule, the OR, all the things he's got to do as far as the testing and whatnot. So it takes a little time to do that. It's not something you come see me and then 3 days later we'll be doing surgery. So keep that in mind. We break it down into 3 operations basically to try and minimize that time when you're awake during the operation, during the main part of the operation. The first stage is usually done a day or 2 before the operation, and these are the little screws that Dr. Calegan talked about. So we bring you into the operating room. It's usually the same operating room or one very similar to where you're actually going to be doing the real operation. So if you get familiar with how that kind of works, some of the people are often the same people on all the different days. And we sit you in the operating room table, and you're awake at this point, and we try and get you as comfortable as possible, try and mimic what's going to happen in a couple of days or so. Sort of a test run, make sure that your head is in a good position, and a lot of people have aches and comfortable positions and whatnot. But then we give you sedation, and most people are pretty zonked out during this point and don't really remember any of what happens after that. You're not really under general anesthesia. I guess it's like a colonoscopy or something like that in the twilight. We clip your hair. We prep it all out, and at 5 sites on your head in different areas, we make a small incision. We actually drill a small pilot hole through the outer surface of the bone, and then we manually screw this titanium screw into your skull. It doesn't go all the way through to the inside, but you can see the threaded portion sits there, and then it abuts the outer surface of the skull. The round portion sticks out of the skin, which is important for localizing. We're going to be telling the infrared camera where these fiducials are, and we can see them on the imaging as well. Once we get all of these in, we wrap your head up and you go get a CAT scan with the same kind of protocol that the MRI was done. This CAT scan actually has these screws on there. And then you go home, and it's important that if you're on medications, we want you to stop those Parkinson's medications, not all your medications, just the Parkinson's medications early enough so that tomorrow morning or 2 days later in the morning when we're doing surgery, we'd like you to have as much of your symptoms as possible. It's hard to know if we're getting a good tremor effect if your medication is already controlling your tremor. So it's a little inconvenient, but it's helpful to us in the operating room the next day. While you're at home, we do our planning. We have the CT scan that we just did, the MRI. There are a variety of standard maps that have been generated over the years, many years ago, that are not based upon your brain, but we use that information, the CAT scan, the MRI. There are standard targets out there. I mean, many of these publications have sort of altered or averaged, how many millimeters this way or that way, or the best spots. And so we take all of that information, we put it on the computer, and we try and plan where's going to be the best place for you and your brain. Everybody's brain is different, so we have to make a little adjustments. And it's not always just this big blue circle that you can just aim towards, always see it just like that. But we do that after clinic, and we sit around and with our whole team, and we do our planning. The next morning typically is the main operation, and this is the part we need you awake and participating for. We bring you in. We usually start around 7, I say. We'll bring you in. You're awake. We get you comfortable in a kind of a beach chair position in the operating room on the table. It takes a little time. Sometimes it can be a little boring, and the patient sometimes may drift off to sleep a little bit. The first part of it, we're really just trying to get everything positioned. Down at the bottom, that's the frame that some centers use. It's perfectly fine. It gives you very good, accurate localization, but you can't go home with a frame while we plan. So you got to put the frame on and then get the CAT scan or the MRI, then to do planning. And so that kind of starts you off a few hours into a day, and we prefer to do the frameless method. So you can come in basically that morning. Anyway, you get comfortable. We get you in that position. We tell the infrared camera where all the screws are. We've already told the computer programming the night before where all the screws are on the CAT scan, and we match it all up. And then we've chosen an entry point based upon your brain anatomy to avoid blood vessels or other things, and we mark that on your scalp where it's going to be. And then we prep your head and get ready to go. You're awake. You haven't gotten any sedation, any anesthesia at this point. And then what we do is where the incision is, it's usually right behind the hairline. We try and put all the incisions behind the hair. Most of us have some hair, fortunately, to hide it. Not everybody. And so, we can try and work with you and be as cosmetic as possible. But whatever the incision is, it's usually maybe about 3 inches long or so. It can be straight, round, different options. But we inject the scalp with local anesthesia. I don't know if you ever had to go to the emergency room, get something sewn up, or had teeth pulled or something like that. It's the same principle. It's not comfortable getting injected, but it's tolerable. And then once it's numb, it's numb. We'll go ahead and make the incision. You are awake. Most people don't typically feel the incision. Sometimes we have to give a little bit more medication. And then pretty much once you're through the skin, you're on the bone, and then most people don't feel anything after that as far as pain. There's not really pain sensors in the bone. We'll drill a hole in the bone. It's typically described as very loud, like you're standing next to a train. Typically doesn't hurt, and it lasts maybe 30 seconds, 40 seconds on average. And then there's a couple of membranes underneath there we open up. Usually they're not painful either. We can anesthetize them if we need to. And then there's a little fidgeting around where we build that tower, that oil derrick that you saw. Sometimes the patients get a little tired and just drift off. That's okay. And usually by about 8 o'clock, we're about ready to go. So your neurologist will walk in the room, and we'll start the microelectrode recording. This is when we need you awake. They'll start playing with your arms and seeing what kind of symptoms you have. We'll listen to the recordings that you've heard some of before, and we'll do this. And sometimes we make a second pass, a couple of millimeters one way or the other, based upon all the different things that we've looked at before in your particular brain and what we're finding in the operating room. And once we find something that seems reasonable, we'll actually turn it on. We'll trial it. We'll give a little current, and we'll watch and see what kind of tremor control you have, or how relaxed your arm or leg may get, and whether you're having any side effects. And once it seems that we've got a good location, we'll put the final electrode in that you saw a picture of as well. We'll do a little bit more testing to make sure that we're getting what we want to get, and that the side effects are not something that's going to impede you from being able to use the device. And then that's about it. Once we don't require you to be awake and participating anymore, we'll give you some medication and zonk you out. Typically, that whole part of it, like I said, may last 2 to 3 hours, typically at the most. Every now and then, patient selection is important. If you're older and you're not as tolerant, you get more tired easily, you get a little fidgety, you're uncomfortable, you got to pee, or this is sore and that stuff. It takes a little longer to make all these adjustments along the way, so we try and just get to it right away. Once you're sedated, we'll go ahead and remove the oil derrick and take all the screws out, and we'll bury the wire right behind the ear here and sew you up, and then you'll stay overnight in the ICU just to watch in case there's any problems. Usually there's not problems. One of the major complications that can happen is very, very unusual, but can happen, is bleeding. And if there's bleeding in the brain, obviously the first way to detect it would be some neurologic change, and so the ICU observation is very important. We'll get a CAT scan either later that evening or in the morning to make sure that everything looks good. The other complication we see from time to time is some people are very brittle on their medication, and when they've been off for a few hours and they've been given some new medications from anesthesia or maybe an anti-seizure medication and some other things, they tend to get off a little bit, and their mental status may change a little bit. And in the end, that usually passes, but sometimes it's unexpected and a little bit more severe than we were anticipating. But almost everybody goes home the next day, usually feeling back to pretty much normal. The only other thing to keep in mind is that just the act of putting the electrode in there causes a little bit of swelling in that area, and you get a benefit from that. The electrode's not on, the battery's not even in, but you'll get some benefit in your symptoms. And but be aware it's going to go away in a couple of days, and you'll be back to your normal self. Then the third part of the operation is done fairly electively. It takes about a half hour to do the operation, to an hour to do the operation, and it can be scheduled pretty easily almost any time. Within a week or two after surgery, you come in as an outpatient, and this is typically done under general anesthesia. It has been done under sedation and local anesthesia, but we usually try and do it under general. It usually goes a little bit easier that way. Most people can tolerate, with medical clearance, 30, 40, 50 minutes of general anesthesia. And all this is just making a small incision here, making an incision here, making a little pocket, just like the pacemaker, like the guy here, he's got one on each side. And we actually tunnel the wire under the skin between the two incisions. We don't make a big long incision. You're asleep when all this has happened. And then we just connect it all up. There's a little lump that's here where the very thin electrode is connected to a little bit thicker electrode, as this one's got to cross the neck and it's got to be a little bit more tolerant. And so sometimes you can actually see the wire under the skin right here, especially if you're older and your skin is fairly thin. But that's okay. Usually the therapy is very, very much worth it. We've had a couple of hunters who don't like it up here, so we can put it in the abdomen. We had some ladies who want it in the abdomen as well, so it's not up there. Some people have a pacemaker. We have to put it on the other side. It can really pretty much go almost anywhere if you plan it appropriately. And it's done in the morning typically, and people go home same morning. And then it's just up to the neurologist when they see you in clinic and get it scheduled. The risks, he talked about some of them. This is an example of a brain hemorrhage. This is not actually from a deep brain stimulator, but that's what it might look like. It could be tiny, it could be larger than that. But it doesn't really happen very often at all. Probably, I think, nationwide about 0.5% or less. And the devastating large ones are not as common. But it can happen, and if it can happen, you can die from it. So it's not to be taken too lightly. Most people recognize that they're at a point in their disease where they're not happy enough anyway, and in the vast majority of people get a good benefit. Infection or malfunction. Infection is a risk with any operation, not too common either. We've been fortunate, but most of the time it's not an infection from the surgery itself. We had one guy had a big pimple in the area where this was, and I think it got infected that way some months later or a year or so later. But it can happen, and the unfortunate with infection is you usually can't just take antibiotics. If you catch it early enough, you can, but if it gets the device itself infected, a lot of times you can't ever eradicate the infection until you take the device out. Once you're healed, you can put it back in, but you've got to go through all that again. And malfunction, also not very typical, but every now and then the wires can break. They're just devices. They can break, or a little screw can come unloose, or fluid can get in, or something can happen. And as long as it's not the one that goes into the brain, it can all be repaired or replaced, and you can still use the same electrode. Obviously the one that goes into the brain can be repaired and replaced, but we've got to go through a lot of that again. Okay, thank you very much.